detox, substance use residential. And so my experience using the ASAM was specifically in that front end piece and the intake assessment, identifying level of care, which is what the ASAM is for. So I'll be starting this, and then Mary Kay will take over as her experience kind of extends a little further past that initial intake evaluation and the process of all the different levels of care. So we first start with what is the ASAM. The ASAM is a level of care assessment for patients with addiction and co-occurring conditions. It can be used for both adolescent and adult populations. It does assist you in developing a treatment plan and assist the managed care and level of care decision making. So a big piece of this is going to be, you might call an insurance company to admit a patient to your residential facility, or to get authorization for chemical dependency IOP or PHP or inpatient level of care. And they may ask you, did you do an ASAM, and how did they score? And so I know I've been asked that many times when I was in the intake department. And so this is it's a nice way to look at their substance use history, to look at all the social determinants involved, and then identify a level of care because they scored this number, and that means that they're appropriate fit for residential or for partial or for IOP. I mean, the reasoning for using it, that's the first one, right? Is your managed care companies and the health plans may request that information while doing a prior auth. That's very helpful to have that scoring system to say, you know, we looked at all these dimensions of their service, of their care and their support system, and how they're functioning in society and how they're managing their addiction. And this is where it landed, right? This is not their first time. They didn't just get a DUI one night out, and they don't have a daily drinking habit or whatever it is. You know, it allows you the opportunity to look at, like, is it a one-time issue and they need to maybe have some court classes or do they need a medical detox, right? And this is what you're looking at. This allows you a general idea of how you can look at that criteria and then say, you know, in addition to knowing that this person needs a medical detox, they scored in this dimension that they really need some service and support. And so when we look at their treatment plan, we can identify ways to look towards the future of their treatment as to what is going to be that next level of care that benefits them, and where do we need to focus, which social determinants are most important, how can we best help this patient succeed with their sobriety or whatever their goals of treatment are going to be. The ASAM comes with 6 dimensions. So this is the at a glance. You can find this online anywhere. And we'll go through each dimension one by one, but to kind of get the quick guide here, dimension 1 is that acute intoxication and or withdrawal potential. Dimension 2, your biomedical conditions and complications. Dimension 3, emotional, behavioral, or cognitive conditions and complications. Dimension 4 is your readiness to change. 5 is the relapse, continued use, or continued problem potential. And then 6 being your recovery or living environment. And this just kind of breaks these dimensions down. Like I said, we'll go through them one at a time, but it gives you an idea of what we're looking at. This is kind of, it shows you kind of that whole person, right? Every piece of their substance use or dual diagnosis. Dimension 1 is the acute intoxication and or withdrawal potential. So with dimension 1, you're looking at their current symptoms of intoxication. Are they currently intoxicated? So when they present to you, are they still high? Are they still intoxicated? Are they under the influence but not impaired? So you'll have those people that, like, you can smell the alcohol, or you can see their eyes are glassy, their pupils are pinpoint, but they don't behave in a way that is like obviously intoxicated. Then it looks at whether or not the patient is under the influence and appears moderately impaired, or is the patient currently sober, and for how long have they been sober? So for those of you who frequently do any sort of intake assessments or evaluations, you know, this comes into question. This is going to be a lot more detailed in your evaluation, right? What are you using? How often? How are you using it? When did you last use it? You know, you're going to be getting into those details. How many times a day do you use it? So when you're looking at that, dimension one, if it's alcohol and they're still intoxicated and you can smell it on their breath and they tell you their last drink was 3 hours ago, now you need to ask a few more questions to identify as their withdrawal potential, right? So are they acutely intoxicated, and then is there withdrawal potential there? So then in addition, so you're looking at those past and present symptoms of withdrawal. Have they ever had a seizure? Have they ever had DTs, delirium tremens? Is there a history of tremors, hot or current, or history of tremors, hot and cold sweats, elevated vital signs, nausea and vomiting, you know, goosebumps, goose flesh, things like that, that you're looking at for that medical piece of the withdrawal. So if they currently having any of those symptoms or they have a history of that. So yeah, I detoxed 2 years ago and I had a seizure, and I had to go to the ER, and then they admitted me for an inpatient detox. That's really important to know, because that person is probably a much higher risk to seize again. If they have DTs, if someone starts telling you, and that's a little bit of our artwork here, if they're hallucinating already, we're in trouble, right? I mean, that's a visit to the emergency room right away. If somebody does not have a secondary diagnosis of psychosis and they are hallucinating from withdrawal, they will likely need an admission to a medical acute facility and potentially the ICU. So you want to make sure that you're asking those questions, or that you know that little bit, whether or not you are seasoned at doing withdrawal evaluations, or you know, being part of the detox protocols. If you see someone in your office, in an agency or something, and you're seeing those that evidence, right? You give them a pen to sign a form and they can't sign their name, their hand is shaking so much. Sometimes when you're talking to them, you can't see the tremors, but when you ask them to complete a task, those tremors become evident. So asking someone to hold their hand out and spread their fingers, asking them to stick their tongue out, you might see their tongue tremor or their face tremor in those situations. Those are helpful ways to identify withdrawal potential, as sometimes there's a lot of patients, especially when it comes to alcohol, who are used to going in withdrawal while they're still intoxicated, depending on their level of tolerance. And so they may frequently have those symptoms and not acknowledge that as withdrawal. I have sat with many patients who have said, nope, I don't have any of those symptoms. And I'm watching a facial tremor, or I can see their hands are shaking, or I can see that their skin is sweaty and that they have goosebumps. And they're like, nope, this is how I always feel. So we want to make sure we're identifying those symptoms, that they're able to tell you which of those symptoms they're having, but then also that you know what to look for when you're talking to somebody. So we're not just assuming they're anxious or something else is going on, but we're identifying that, wait a minute, I'm seeing all of these. Did you have a question? Sorry.
No questions have
Okay,
popped
sorry.
up yet.
I heard talking. And so we talk about how to check for tremors. And that then leads us into dimension two. So dimension two looks at those biomedical conditions or complications. And so is there a complicating risk of withdrawal, right? So I automatically, depending on the substance of use, if it's alcohol or benzodiazepines, your risk for withdrawal, seizures, or withdrawal stroke from elevated vital signs is higher. And for alcohol, you're worse on your 2 days out. So if someone presents to you and they've been drinking daily for many days or many months, and their last use was 2 days ago, and you're seeing a lot of these symptoms, this person needs to be medicated pretty quickly, right? Or you risk that withdrawal seizure or stroke, depending on their vital signs. You also want to make sure that if they have any other chronic medical issues that might affect that withdrawal potential. So if they already have a seizure disorder and they are not taking their seizure medication, or they are abusing benzodiazepines or alcohol, that person's going to be at higher risk to have some co-occurring medical issues. Sometimes you'll see patients that already have hypertension, diabetes, history of strokes, those sorts of things you want to be very careful about. Alcohol can cause other medical complications, gastrointestinal issues, esophageal varices are really common. So they might be vomiting blood because they have those vessels are breaking in their esophagus. And so they might be spitting up or vomiting blood when they get sick from the withdrawal, or when they have a hangover, if they vomit from being too intoxicated. You can see things like that. You might see co-occurring liver disease, cirrhosis of the liver. Their skin might start to look yellow. So you'll see those side effects, and that person's going to be higher risk because at the point where their liver is not functioning appropriately, they're not filtering the alcohol the same. So, and that same with, you'll see a diabetic person that might be able to drink very little amounts of alcohol and be very intoxicated from it because they're not metabolizing that alcohol exactly the same as someone else might be without that medical complication. One other note in this area is the bariatric surgeries. So when you see people that have had a bariatric surgery for weight loss, frequently you trade the addiction, right? So they trade the food for the alcohol or a pill, and you'll see someone that's had a recent bariatric surgery start to have addiction issues. They also don't metabolize their food or drinks the same when they've had their stomach changed, whether it's a sleeve or a full bypass. There's different things that can go on with that can cause them to be able to drink smaller amounts. So you can't just judge by the amount they're drinking. Like, you have to judge by the symptoms, by their vital signs, by the other story that they're telling you, because someone that has a history of running marathons, their vitals they might have a high blood pressure but a low pulse still, and a 65 pulse might be high for them. And so you have to take those things into consideration when you're looking at the withdrawal potential. You don't want to overlook something that could be a medical complication for them and then come to find they have a withdrawal seizure, end up hospitalized medically because we just assumed a 68 pulse was not that high. But for that person, it might be. So we want to make sure you're taking everything into consideration when looking at these two dimensions. On to dimension 3.
All right. So as Julie and Janelle both mentioned, my background is a lot in the outpatient side. So I worked with women in recovery, assessing them, doing the ASAM, assessing and reassessing. And then I also worked with medication-assisted treatment patients. So I use this quite a bit in my practice. And the cool thing with working in the outpatient is you're able to see that progression, so three months in, 6 months in, you're able to reassess and do the ASAM, which we'll get into towards the end about the benefits and the progression with the ASAM. But so with Dimension 3 is our emotional, behavioral, or cognitive conditions and complications. So really in this dimension, we are now looking at the current psychiatric conditions. So we're focused on the psychological factors, cognitive problems, so the co-occurring pieces, the depression, the anxiety, bipolar, ADHD, how that's affecting the substance use. And we're also looking at if there's any intellectual disabilities, dementia, Alzheimer's, all those things play a part in assessing this dimension. Some questions that I liked when I was doing when I was used to do the ASAM, I like to ask a lot of different questions to assess. So in this particular dimension, I would ask, are there current psychiatric illnesses or psychological, behavioral, emotional, or cognitive problems that need to be addressed because they create or complicate treatment? Are there chronic conditions that affect treatment? Are they able to cope with their emotional, behavioral, or cognitive problems? Do they have coping skills? Are they able to identify their triggers? And that'll give us a good idea of what level they fall into with this dimension. Another piece of this is medications. Are they compliant with medications? And that'll give us an idea of how they're able to, cope with their conditions. Okay, Dimension 4, so readiness to change. So this, if you're familiar with SATS, the Substance Abuse Treatment Scale, and the stages of change, we're able to see where they're at with, their motivation level, their willingness to change. I used a lot of the stages of change. So you're looking at, pre-contemplative, contemplative, action, maintenance, preparation. And then with the substance abuse treatment scales, we're looking at, are they in pre-engagement? Are they engagement, early persuasion? So we're able to really identify if someone's coming in and they're denying any problem at all. They're denying any substance use, but they have a long history of alcohol use and they've tested positive. We could say that they're in a pre-contemplative state. So, asking questions like, what is the individual's emotional and cognitive awareness of the need to change? Are they aware that there is a problem? Are they in denial? What is his or her level of commitment to and readiness for change? Do they have some treatment history? Have they engaged in treatment before? Have they been successful? What is what is their degree of cooperation in treatment? So again, were they consistently engaging? Did they come here and there? So it's really important that we're able to gauge that in order to see where they're at on that scale of ready to change. Okay, now with Dimension 5, relapse, continued use, potential, or continued problem potential. So here we look at danger to self and danger to others. So as the patient presenting in front of us have active suicidal ideation, are they having a plan? We need to really gauge where they're at with SI and HI, homicidal ideation. We need to look at triggers for relapse. So again, are they able to identify what triggers them to use? Look at how symptoms would continue or progress if not treated. So some of the questions I would ask myself here: is the patient in imminent danger of continued severe mental health distress and or alcohol drug use? Does the patient have any recognition, understanding of, or skills that they could cope with in order to prevent relapse? So again, looking at those coping mechanisms, do they have any type of tools to utilize to help? How aware is the patient of the relapse triggers, way to cope with cravings, and skills to control impulses to use or impulse to harm self or others? So this will give us, by asking those questions and evaluating, it'll give us a good idea of where they fall as far as the relapse and the continued use. Okay, now with Dimension 6, recovery and living environment. So in this dimension here, we're looking at a person's living situation, their work situation, if they have one, school, family, what supports do they have? Are they living with a support who is using? Looking at social determinants, transportation, childcare, housing, all of those social determinants that play a factor in their use. So, some of the questions here that I would ask: do any family members, significant others, living situations, school or work pose a threat to the patient's safety or engagement in treatment? Does the patient have supportive friends, financial resources, or educational vocational resources? And a lot of patients might say that their supports are also, the ones who are using with them. So we really have to evaluate, are those supports for your treatment? Probably not. So it's a good way to gauge, are there legal, vocational, social services agencies? So, any legal issues going on that could, affect your treatment? Do you have a probation officer, a parole officer? And then again, the transportation, the childcare, housing, employment, I think we've all seen it can be a lot harder for patients. I worked with a ton of patients who were homeless. I think almost 98% of the patient population that I worked with prior to this job were homeless. And so that was really hard. So we had to work very hard to get them some type of housing, a halfway house, residential, so they can have that stability and that support system there in order for them to be on the road to recovery. So I think this dimension is very, very important in evaluating in order to determine the level of success that they're going to have, and then what also the team needs to work on to help them be successful. Okay, so Julie and I will do this one together. When you look at it initially, it might look a little overwhelming, but here's the positive thing with the ASAM, and in all my experience with the ASAM, every electronic medical health record had the scoring built right into the ASAM. So really the most important piece to this is just knowing what each level of care is. That's the most important piece, because like I said, it'll do the scoring for you. So let's see here. So we'll just go through each of the scoring and each of the different scoring pieces and talk about what that looks like. So, if a person, so they do it based off of when they're scoring in the dimensions, they'll do it based off if it's none, mild, moderate, severe, and then it'll place you in this continuum here. So for instance, early intervention, a DUI program. So this is the individual that, is higher functioning, has engaged in treatment, has a support system, has some stable living environment, and they really just need like an AA or an NA, or they're just going to drug test. They have a job and they're working full time. So this is your higher functioning patient in this level here. And then so outpatient treatment. So if someone scores in this level here, you're looking at, some counseling. The individual is also their higher functioning. They might have had a recent relapse. They've been doing really well, but something happened in their life and they need some counseling and maybe to get on some type of medication to help stabilize. Anything to add in the dimension pieces as we're talking about it?
Yeah, I mean, I think one of the things with this is confusing when you look at it initially, and like there's no easy way when you look at the ASAM, any of the information online or outside of the different, like Mary Kay said, the different EMRs, taking it and putting it into like a scoring tool. So at the last place that we worked, the EMR had loaded in a scoring tool where it had each of those, like in the prior slides where we said, okay, the dimension 1 looks at these 1, 2, 3, 4, 5 things. It allowed you to click on 4 things, 4 different options. 1 would be none, 1 would be mild, 1 would be moderate, 1 would be severe. And it told you what those things were. So if this person's scoring in this level, that they have no issues with withdrawal, or they're not intoxicated, there's no withdrawal potential. Okay, that's a 0 on that one. There's none for that dimension. And then it goes through each dimension like that. So this kind of breaks it down for each one, where you're looking at like intensive outpatient, it's going to say dimensions 1 and 2 are stable. So there's no biomedical conditions. They're not in alcohol withdrawal. They're not acutely intoxicated. Dimension 4 is, or it'll say, dimension 3 is mild and 4 through 6 are mild to moderate. So the example would be, and we're going to plug ourselves here, you can refer that patient to St. Luke's IOP program, and they'll get an intake and start therapeutic groups 3 times a week for the next 8 weeks to support them in maintaining their sobriety and managing relapse prevention, right? Or they might go to Aurora or the Meadows or a different IOP program in the community, but you've got that kind of level of care is looking at like across most of the dimensions, you're mild to moderate, but there are no medical issues. And then partial turns into dimensions 1 through 3 warrant some monitoring, right? So, hey, you're not in acute withdrawal, but I want to make sure you stay that way. And so I want to see you every day, and I want to check your vitals, and I want to make sure you're okay. That person could come into a partial hospital program where they meet with a nurse every day, where they go to their therapeutic groups, where there is a provider on staff, a nurse practitioner or a addiction medicine doctor that can check in with them and just make sure they stay stable, right? Can maybe provide comfort medications via prescription if they need it, but they don't need to be hospitalized at that point. And so that breaks that down. And then those psychosocial, other social determinants, the dimensions 4 through 6 are moderate or severe, and that they need a lot of support. Basically, that person can sleep at home, but they need to come in every day and get some support for a week or 2.
And then the next ones, as far as the residential, as you can see here, there's a few that are all residential treatment. And so those next levels, It's, residential treatment. It could be, a halfway house or sober living if it's not severe enough to be to like a 24-hour. So, so it says halfway house or sober living. So problems in 5 and 6 are moderate to severe. So, and I can't think off the top of my head what 5 and 6 are. I'm drawing a blank here.
So the recovery
relapse,
environment.
right, the
Yeah.
relapse
So maybe
recovery.
they're homeless. Maybe the people around them are using. Maybe they don't have a very good support system, but they don't have a co-occurring mental illness. They're not in active withdrawal. There are no significant medical conditions. They have insight, right? They have some awareness and they want to engage in treatment. And that might be an appropriate level of care for them. They want to work, they want to be out in the community, but they need a supportive living environment so that they don't come home at night and use their substance, right? Then the other residential, the extended or long-term care is more high intensity. That's your dimension 3 is mild to moderate. 2 of 3 of 4 through 6 are mild to moderate. And so this talks about like maybe these are the Florida model. So you really need some more support and engaging, right? They're not engaging as much in treatment. They maybe don't have as much insight. They need a little more intensity in their treatment. This is like the Florida model, Desert Cove Recoveries, Pinnacle Peak, the places where you live in the house and they drive you down the street to the PHP program every day. But it's a supportive, sober living environment that has programming throughout the day. And then the third one's that medium to high intensity where the programming, like a rehab, where the programming's happening in the same place where they're staying. So that's, Ascend, Lifewell, Crossroads, where all of their services, it's more of like a rehab facility, Calvary, Valley Hope, where someone's going to stay for 30, 60, 90 days and be in a more intensive treatment environment, but they're not a medical risk. And they don't need that level 1 detox.
Yeah, and then you have your highest intensity residential where it's kind of going to be your one-stop shop. So you can see your PCP there if you need to. Those are going to be your Calvary Rehab, your Valley Hope. So it's where you would go when you don't quite need that hospitalization, but you need that 24-hour. You need every support you can possibly get because, you are in denial. You don't know that you're having a problem, but you're almost there. You want the help. And you don't have any supports at all. Your willingness to change and engage is low. Yeah. So all the dimensions you're scoring pretty high in order to meet that level of care.
And those are the people that they might have failed multiple other levels of care, right? So when you're justifying a decision like rehab to a health plan or a payer source, they were going to say, well, what if they tried? You don't come in for your very first time in treatment, unless you're privately paying, and get the insurance to cover it if you're saying, well, I've never had treatment before. This is the first time I've sought treatment for my substance use disorder, and I want to go into a 30-day rehab. Usually the insurance company is going to say, well, what else have you tried? Have you tried an IOP? Have you tried a PHP? Have you tried these other models? And that might be a person that could benefit from the second level residential treatment where they go into like a Florida model program where they bill it as a PHP, but you still get the housing and the support in the living environment. That person might benefit from that level of care, having not failed multiple levels in the past. Whereas going into that highest level, the Crossroad or the Calvary, the rehab places, Vogue, those sorts of places, you have to have failed at something in the past in order to get the insurance company to agree to pay for that level of care for that length of time. And then the last one's the inpatient. And so this is your 1, 2, and 3, right? Your 1, 2, or 3 are pretty severe. And this is, you're going to a level 1 psychiatric facility. Plug. St. Luke's, Banner, Valley, Aurora, all of these level 1 psychiatric facilities in town. If we're talking, out of county, you've got Tucson hospitals, Sonora, Palo Verde. There's some Banner Hospital there. I mean, there's some options across the state of Arizona that do the level 1 psychiatric inpatient, but have a detox protocol, have a detox unit, have addiction medicine doctors or psychiatrists that do the safe medical detox and can handle a problematic medical patient if things were to get complicated with their withdrawal, and can medicate safely, can monitor 24 hours a day for the 3 to 7 days, depending on their withdrawal. Now, I want to just one little bit of information on the inpatient treatment. A lot of the health plans are no longer covering opioid detox. And so a lot of people are only getting their detox withdrawal protocols taken care of in the hospital because they have a co-occurring illness. So they might be coming in suicidal with major depression and having heroin addiction. Then they would get admitted under the psychiatric diagnosis, and the medical detox would happen that way. But it is harder nowadays because the medical detox from opioids is not life-threatening the way a benzodiazepine or an alcohol detox is. You're going to see that problem occur. And then hopefully this isn't, well, who knows? Everybody's a little different with their knowledge of the withdrawal protocols, but marijuana, cocaine, amphetamines, spice, things like that. There is not medical detox for that. So that's not something that's covered by somebody's insurance for medical detox. You will sometimes see like somas, muscle relaxers, or certain muscle relaxers that will require a medical detox. But most of the time, for amphetamines, if someone gets admitted to the hospital, it's usually the secondary psychosis or aggression, the danger to others or danger to self that puts that person into the hospital. But there is not a medication protocol for taking somebody off of a stimulant or marijuana or other substances. So it's primarily your alcohol, your benzodiazepines, and your opioids that do have appropriate medical or medication tapers to safely taper somebody down over a certain number of days. But it's become harder and harder to do that with the opioid population, which is why these MAC clinics that are all over the valley are so helpful, because sometimes that's the better option, is to do the medicated assisted treatment and then taper them from there over a longer period of time, so that they get that support and the counseling and the treatment in that location over a timeline. All right, so I guess let's stop for any questions before we go into the case study. Is there anybody that has any questions for us before we start talking about these patients and what they look like?
There aren't any questions in the Q&A just yet.
Okay, so we are going to ask some folks to get involved here for this part. So this is pretend patient Billy Smith. Billy's a 56-year-old male presenting with alcohol dependence, drinking a fifth of vodka daily for the past year. Last drink was 36 hours ago. His longest period of sobriety was for 60 days, about 14 months ago. And he's been drinking almost daily since college. So we're going to assume college ended in his early 20s. He's got 30 plus years of daily drinking. Current symptoms include tremors, vomiting, chills, muscle aches, history of seizure 2 years ago. Billy denies use of any other drugs except for marijuana use during his teenage years. He lives in his own home with a girlfriend. Girlfriend drinks with him about 3 times a week, though she's not a daily drinker. He states he has come for treatment so he won't lose his job, as his coworker reported him for smelling of alcohol at work. So what other questions, we'll start with this. What other questions would you have for Billy to get an idea of how you're going to score this ASAM? I think we have dimension 1 taken care of, right? Who has an idea of what else you might want to ask Billy to get a better idea where he's at with treatment?
If you would prefer not to speak, you can also type in the chat. It looks like we have other chronic conditions.
Okay, awesome.
From Bridget.
Anybody else?
Anyone else?
It's hard to
Um,
participate in a virtual training.
Someone had asked what level of treatment Billy is seeking. So maybe like Billy's willingness, what he would like to see happen, readiness to change, and then also, yeah, if he has any motivation to stop drinking beyond not wanting to lose his job.
Right.
If there are any other reasons there, yeah, and willingness to change, readiness to change.
Good. Good. I mean, and that covers a lot of it. I mean,
And then, sorry, one more that came in that's also important is if anyone else in his life is worried about his drinking, and then if he's ever sought out treatment before.
Awesome. Good. Right, because we know that he had sobriety for 60 days, but we don't know how he got there. We don't know if that meant so it's very different to say, well, I self-detoxed at home and I stayed clean for 60 days by going to AA and staying active with my family, than somebody who tells me I was forced into detox, I was hospitalized for 3 days, got a medical detox, and then I stayed sober for 60 days because I was in a residential program the whole time. And when I discharged, day of discharge, I started drinking again, right? That's a very different motivation level for someone who says, I'm only sober when you lock me into a facility and make it so I don't have access to any alcohol, than it is somebody who's saying, I was motivated, I did really well, I participated. Hey, what happened? Why'd you relapse? And then they say, oh my gosh, I was at a family barbecue and someone offered me a beer and I thought I can have one and it won't be. And the next day I'm drinking 30, right? I mean, I probably heard so many different stories similar to that over the years, but those are the sorts of things, you want to be able to know, in addition to, well, how does he cope?
Is he aware of his triggers? Does he know what leads him to the drinking?
Right.
Someone else had put in the chat, does he have any court involvement, or does he have a psychological diagnosis of any kind?
Right. So is there a dual diagnosis? Is Billy experiencing depression or anxiety and he's been self-medicating, and maybe with a psychiatric intervention, he will do better? I would want to know his family history. What if all of his male relatives had alcohol issues, and it from his parents, his uncles, his grandparents, whatever. A lot of times you'll hear that and it's like, boy, this one's going to be a little harder because it's almost like genetic. There's more to it than just the coping. It's a combination of things that come into play. That's kind of, you want to get that whole picture. You want to be able to ask all those questions. You want to know, what is he willing to do? I like that someone brought that up, because at the end of the day, it's not our treatment plan to build for Billy. It's Billy's treatment plan to make for himself. And so you'll hear, I do a lot of, I've done a couple of different speaking engagements on discharge planning and patient engagement. And a big piece that I think needs to change drastically is that we need to be able to say to somebody, what are you willing to do to change? Or do you not want to change? Because admitting somebody for medical detox who tells you, I need this right now because I don't have money to buy the alcohol, and I know if I don't do this, I'm going to have a seizure, is a very different patient than I don't want to live like this anymore. I want to make this change. I've admitted both because they both need it. But it's hard when you're looking at someone who says, I have no intention of staying sober, but medically they're so high risk, I have to admit you, right? But they are not motivated for treatment at all. This is just basically to get them through until they've got the funds to buy more alcohol. That happens. And at the same time, there's the people that are like, I want this to stop, but I don't know how. And so our role in that is to provide them ideas for treatment planning that they're willing to buy into, right? So the treatment team comes together and says, all right, Billy, we know all this about you. You score on the ASAM. I mean, I'm going to say right here, Billy's he's going to score high enough to go inpatient for medical detox from how long he's been drinking, the past that he's got the withdrawal symptoms, and he's got a history of seizures. He's going inpatient at first, but then we have to, once we've got him out of the medical piece and his dimensions 1 and 2 are managed, now we've got to look at 3 through 6 and identify what's the next level of care for Billy going to be and what's he buying into.
And the ASAM, it is important to remember that the ASAM is built to be very individualized and person-centered. So those conversations are very important to have of what is the patient willing to do. If they meet that level of care of a PHP, so hey, 5 days a week, but the patient isn't willing to do that, they're not there yet. Okay, well, let's talk about going 3 days a week. Let's talk about going to an IOP to start off with. And making that a part of your treatment plan, and let it be their decision. That is very important to give them that autonomy.
Right. And sometimes you got to take what you can get, right? And if you're going, oh my gosh, this person needs this because they can't go back to a home where girlfriend's drinking, right? They need residential. And he says, I'm not willing to do that. I need to go home. I need to go back to work. I will only do the IOP program in the evenings, after work, 3 times a week. And that's all, right? Then it's okay. Well, let's see how we can support you with that treatment plan in place. And although his score on the ASAM may identify the need for residential, that's not what they're willing to do. We got to go where the patient's at and start supporting them at that level. And then if they fail that level, then we can have another conversation, right? About what's the next level up that might be more supportive for you. I can get not wanting to leave your home environment or not, but then do we need to include girlfriend in treatment? Do we need to identify if she's willing to have all the alcohol out of the home, or what are they willing to do together? And this might lead to a couples session. This might lead to involving her in IOP family night or whatever it is, but making sure that we're doing what we need to do to support that patient's decision for their care. So, I mean, I think we answered our question. What level of care does Billy require? I mean, at this point, he's going into the inpatient medical detox to start. Let's look at a different one. So this is Mary Collins.
So Mary Collins, she is a 24-year-old female with substance use disorder, including amphetamine and opioids. Mary is using Percocet 250 milligrams, about 3 pills per day for 3 to 4 days per week. On those days that she's not using Percocet, she's using meth. Mary uses methamphetamine 3 to 4 days per week by snorting 1 to 2 lines twice a day. She has been using since she was 19 when she dropped out of college. So, that puts her at about 5 years of use. Mary's last use of Percocet is 4 days ago. Last use of meth is 3 days ago. So she's had consistent use for about 5 years. Mary was living with her family, but they kicked her out last week, and she has been now living on the streets. Mary has minimal supports locally. She is close with one sibling who lives in Florida. She has never been in treatment before. So again, let's get some ideas of what other questions you would ask or need to know about Mary in order to assess level of care.
Looks like someone mentioned dimension 3. Does Mary have a mental health diagnosis?
Okay, good. What else?
Does Mary have access to safe housing?
Okay.
Anyone else? What led to her dropping out of college?
Okay, good. Yeah, that history is definitely important to get. Sorry, go ahead.
Sorry. The next one, which I thought was interesting, is she pregnant or does she have children?
Okay. Yeah. And all that will determine what treatment she's willing to engage in. Maybe she doesn't want to go into a residential because she can't leave her kiddos, but needs to go into some type of, housing where her kids are able to be with her during this time because she has no support to help her.
Right. So, I mean, we have essentially a homeless 24-year-old who's using two different substances. She probably won't meet level 1 criteria, right? So this one's not going inpatient at the level 1 for her dimensions 1 or 2. But her dimensions 3 through 6 are all pretty moderate to severe. So if we identify that she is without children, this person, what level of care are we looking at? Right? I mean, I think this one can go a few different ways, but I would say one of the 3 residentials, right? Because she could definitely have some housing support right now while she manages her illness. And then, like you said, we have to know, we don't know if she's got a co-occurring behavioral health issue or mental health issue. We don't know, quite a bit about her. So, and obviously a full psychosocial is going to tell us a lot more. But this is meant to engage you in looking at, we know a little bit about her. We don't know her dimension 2 in particular. We don't know if she has any medical problems or comorbidities that are chronic medically. We don't know if she's engaged in treatment or not, right? She's never been in treatment before, so we don't know her level of motivation, her buy-in to treatment. But looking at this and having asked more questions, I would say the residential.
Yep.
Someone did mention that possibly she could get medications for the opioid treatment as well.
Right. So she might be someone that benefits from MAT programming, so Medicaid MAT program, in addition to a residential or a halfway house. So she might go to a sober living environment where she has to work for her stay, right? And it teaches her the job skills. It gets her back on her feet. It makes her feel productive. She goes to NA or AA meetings while she's on the property. There's supportive staffing there. And she hits her MAT clinic every morning for some Suboxone to manage those cravings and manage her opioid symptoms.
And again, that's why it's so important to know, whether she's working and what kind of support she has. And if she does have kids, that's a great question, because that can determine whether, she wants to if she wants to work, okay, perfect. Let's look at a halfway house. If she doesn't want to work and wants to fully commit to her sobriety, then let's look at a residential.
So the last one is George Valdez. George is a 40-year-old male with dual diagnosis of major depression, depressive disorder, and benzodependence. He's been abusing Xanax, 0.5 milligram tabs up to 8 in a day for his anxiety and depression. For the 6 months, he did this for 6 months. His doctor stopped prescribing it, and he has been without it for 14 days. He's recently divorced, hasn't been able to see his children, causing significant depressive symptoms. He was first diagnosed with major depression in his early 30s after his first child was born, and he started to have marital discord. He has a stable job and home environment. He has supportive family and is very religious. He has tried brief therapy in his early 30s, but hasn't attended therapy consistently. He was hospitalized one time at age 39 for suicidal ideation when his wife first talked about the divorce. So what else do you want to know about George? We gotta give people time to type.
Yeah. So first thing that's come in is, is George having withdrawal symptoms from the Xanax? Does he have current suicidal ideation? And then at the same exact time, someone else puts current suicide risk.
Good. I mean, I think, so George is 14 days out on using any Xanax. Can he still be in active withdrawal? Did anybody answer that? That
Somebody put possibly with the benzos.
Yeah, so benzos take a long time. So a benzo detox can sometimes last up to 7 to 10 days. And I've actually seen people discharge from the hospital after a benzo taper and return a day or two later with what would be considered a residual withdrawal response. And they end up having more symptoms and actually start to look like they're in DTs. They'll start to have psychosis and other symptoms. And so they'll have to be tapered again, usually using like a Klonopin with a Depakote support for seizure risk. And so you definitely want to assess George for that, because 14 days doesn't mean he's in the clear. But let's say he is in the clear, then let's talk about what level of care does George require.
There's another comment in here that said, just because his doctor stopped prescribing them might not mean that he doesn't have access to them.
Very true.
Right.
Meaning buying them off the street or going to the emergency room.
Yes, that's very true. I once admitted a patient. It was she was actually pretty surprising for all of our admission team and the doctor, that was getting opioids. She was getting Percocet from a doctor for a pain. She had injured her back. She started taking Percocet. When they stopped prescribing them, saying, okay, you don't need to be on these medications anymore, she started buying them on the street. She couldn't afford it because the pills are more expensive. So she switched to heroin, thinking that that was a cheaper option. And by the time we caught her, she was so sick in my office that day, because she had weaned herself up to six. It was unbelievable. 6 grams of heroin a day.
Oh, wow.
And she had only been on any opiates for, I mean, it was like less than a year. And she had put herself on this huge amount of heroin daily. And then she had gone cold turkey. So by the time I had her in my office, she was about 30 hours out, and she was beyond ill. I mean, she was so sick. It almost looked like if you tried to cold turkey someone off of like 200 milligrams of methadone. She was very ill. And obviously that's not an opioid withdrawal that you say, no, your insurance won't cover it. She was too sick not to admit her. But she did that on her own, using street drugs to to take over for what her doctor stopped prescribing. So that's a really good point. It is not that difficult to get benzos, especially if you cross the border. Benzos and muscle relaxers and even opiates are very easy to get in Mexico and not that expensive. So, that's an easy pill to get if you're wanting to continue using it. So that's a good point. We need to make sure we're asking George, are you continuing to take the meds? Your doctor cut you off 14 days ago, but have you used anything else? And to get an idea.
Yeah, and I think also looking at, when he was first diagnosed with the major depression, how did you cope during that time? Yes, he did some brief therapy, but what were some of his coping mechanisms during that? And I would really say that this individual would be an outpatient candidate, some counseling, maybe some medication to help manage the depression and the anxiety, and then some group, to hit that substance use piece as well. Because we definitely want to take into consider both the substance use and the psychiatric piece. So, maybe some NA or AA to help with that.
Yeah.
Someone did mention IOP.
Yeah.
As George being an IOP patient.
I think that's a good start. And again, IOP is not forever, right? It's usually an 8-week program. So you're looking at sometimes when someone's contemplating with like committing to 3 days a week, 3 hours a day, something that intensive initially, it's 2 months of your life. Yep. 2 months ago it was Christmas. I mean, it seems like it was just yesterday. You're going to get past it that quickly, right? So when you're looking at that, like sometimes getting them to identify that it's let's think about this level of care, and then you can step down from there. Then and then, or does he need a co-occurring? Does he need to be an IOP and be seeing a psychiatric provider for his major depression? And so maybe you're combining two of these levels to identify the needs for George specifically because he's got a co-occurring diagnosis. So IOP might be really helpful for him, but maybe there's a dual IOP that addresses the mental health. I mean, I would suggest most IOPs address both, but a lot of them, there are programs that address both. And then there's a provider attached that can prescribe the medication he might need for his major depressive disorder while he gets the supportive groups and the sobriety and the relapse prevention training and that sort of piece of it. So, yeah, thank you guys. That was our last case study. I know that we only have a few minutes left. Are there any questions? It's a big topic for a short amount of time. So hopefully we didn't rush through any of this for you, and it gives you a little better understanding of the 6 dimensions and how to look at it and score it and use it to your benefit when you're seeing an SUD patient.
Yeah, and hopefully if some of you do have the ASAM in your EMR, your electronic medical record, now you can go back and really have a good idea of what questions you need to ask and what the dimensions look like, because it really doesn't explain it on the EMR.
Someone did ask, are there any special considerations with access?
With access payment?
Oh, like access, yeah, like for payment.
For
Insurance?
Yeah, like insurance.
Yeah, I mean, so if you're identifying, like if you see a lot of patient population that have access as their payer source, I mean, it depends on what their needs are. So most of the MAC clinics do take access. I mean, I can say for St. Luke's purposes, all of our programming accepts access, whether it's IOP for mental health or substance use, our soon to be opening walk-in clinic, psychiatric clinic is going to have access. The inpatient offers access. So there's a lot of programs out there that take access. Now, when it comes to the higher levels of care, the residentials and those, so there is coverage for residential services with access, but they really have to go through the process of failing other levels of care first. It's not as easy to push somebody through, but there are places, Unhooked Recovery takes access, Ascend, Crossroads, Maverick House. There's a lot of different places that take access at that level for the residential. And then there's a lot of, IOPs and PHPs that take access. We have substance use PHP and IOP, so full day and the 3 hours, 3 times a week. That and will also help. Transportation ends up being a big barrier with that population. And so we will set up transport through via the Access Cabs, VEO, or whatever contract they have to get them to and from the groups to help increase their likelihood of participating and showing up once they've been evaluated for that level. But I do think Access strongly supports this. They have a big, strong team that's pushing the opioid education and treatment. And so they've got their different centers of excellence. And the REBA puts out a book that covers all the in-network providers. I think our time is up. Janelle, is there anything else? Questions pages.
Oh, you're on mute.
Sorry, I started my video and not my audio. I just wanted to say thank you very much for the presentation and everyone for your participation. And then I just wanted to mention if anyone had any outstanding questions, to just send me an email and I can see if Julie and Mary Kay are able to answer those. We don't have any typed in, but just in case.
Okay.
And then I just wanted to mention as well, our next webinar will be on March 24th. from 12 to 1, same time, a Wednesday. It's going to be on co-occurring disorders with focus on SMI and SUD. And we'll have an LCSW from one of our health centers speaking on that webinar, Catherine Chandler from Circle the City.
I've worked with Kate. She's fabulous.
Yeah, we're really excited to have someone from a health center speaking.
Yeah.
She's got a lot of knowledge in the area, so we're excited about that, and everyone can be on the lookout. I'll send that invite before the end of the week this week. But thank you everyone for your participation, and thank you to Julie and Mary Kay.
Thank you guys.
Appreciate it.
Bye.
Bye.